So I welcome you all to my next video on fluid therapy in ICU. So fluid therapy in ICU might seem like a very small or basic topic, but it's very important because there are like certain nuances which everyone should know. And most of the times I've seen doctors randomly prescribing NS, RL, DNS without knowing what is indicated and for whom it is indicated. And I've seen doctors using colloids like starch telefusion as well. So it's very important for the critical care trainees, intensivists, anesthetists, ER physicians, and general physicians. Mm, So try to simplify this. Most of the content here is from various articles and from ICCM textbook of critical care. So we'll start with the session. So I'm going to cover this in four headings. That is, what are the type of fluids, what to give, when to give, and how to give. So we all know the types of fluids. They are basically classified as crystalloids and colloids. And crystalloids are further classified as isotonic, hypotonic, or hypertonic. Depends upon the osmolarity or tonicity of the fluid with relative to the body or plasma's natural osmolarity. So isotonic means when it's the osmolarity of the fluid is equal to or close to the serum levels. Because of this, whatever fluid you give is going to stay in the extracellular fluid compartment, that is your intravascular space. This further has two types: balanced salt solutions or balanced crystalloids and unbalanced solutions. Your plasma light, RL, etc. comes under balanced, whereas your normal saline is unbalanced. This is because the electrolyte composition of these fluids are more physiological and more close to the natural serum levels, and the osmolarity is even more closer to the normal serum osmolarity. Whereas in NS, it's not like that. It's slightly hyperosmolar. I'll be showing you the contents of each of these electrolytes. Next is hypertonic. This is when the osmolarity of the fluid is lesser than the serum osmolarity. When when you say a fluid is hypotonic, it means it is having more water and less electrolyte concentration. Because of this more water content, when you give this in the IV line, it enters the extracellular intravascular space. Because of more water here, this more water moves into your intracellular space, thereby causing cellular edema. Example is your half NS. This is having exactly half the content of your normal saline. And one peculiar thing is your dextrose. 5% dextrose is having dextrose with a free water. So in the dextrose bottle, it is hypotonic. But once you give the 5% dextrose inside the body, the dextrose is metabolized and this acts as a free water. And this free water is hypotonic. Okay, so it is isotonic in the back, but once it goes to the body, it is isotonic. And this free water reduces the sodium levels. Okay, next is your hypertonic. Hypertonic is when these fluids have more electrolytes and less water content. They are more than the serum osmolarity. Because of this, once you give it in the IV line, they have less water and more electrolytes. Because of this, the extra water from the intracellular space goes into the intravascular space. And because of this fluid shift from the intracellular to the extracellular, they reduce the cellular swelling. So this is the reason why they exert anti-edema effect. Okay. Examples include 3% saline, 5%, 7%, 20% saline. They have a slight anti-inflammatory effect. Because of this hypertonic nature and shift of the fluid from the intracellular to the intravascular space, they cause a rapid intravascular volume expansion. Okay, so good volume expander, they reduce the need for further crystalloid administration, but the downside is they have a very high fluoride content, which cause more adverse effect. So the harm is more than the benefit. Other examples include dextrose containing fluids such as 10D, 25D, and 50D. Similarly, like 5% dextrose, you have DNS. DNS is nothing but the 5% dextrose, and instead of the free water, it is having normal saline. So once you give this hypertonicity, once goes inside the body, the dextrose is metabolized and behaves as a normal saline. This behaves like a free water and becomes hypotonic. This behaves like a NS and becomes isotonic. Okay. So that is about crystalloids classification. Next is colloids. Colloids, there is natural and synthetic. And in natural, you have albumin, fluorescent plasma. Okay, albumin usually we use 4%, 5%, and 20% albumin. They come as salt rich and salt poor form. Mainly albumin, they have the capacity to maintain the oncotic pressure, thereby reducing the interstitial edema. They also have a little bit of pleiotropic or antioxidant effects. Okay. There are only certain indications of colloids or albumin. We'll see it later. Okay. So other colloids, synthetic colloids such as hetastarch, gelofuscin, that is starch-based and gelatin-based, are totally abandoned and not recommended. And please don't use them. They cause more harm than benefits. Okay. There are two types. One is starch-based and gelatin-based. Gelatin-based having 3 times more anaphylactic reactions compared to starch-based. And both of them are metabolized in the renal. So both of them have tendency to cause acute kidney injury, coagulopathy, and allergic reaction. As I said, this is three times more in gelatin-based gelofuscin. So this is the content and osmolarity of your balanced crystallites. I mean your crystallite solutions. See, NS is having a 154 sodium, milliequivalent of sodium, chloride of 154, which is way above the physiological upper limit of 108. So total osmolarity is 300, slightly hyperosmolar. Okay, and RL is somewhat closer to your normal serum plasma osmolarity of 290, and it is having physiological content of sodium, potassium, and chloride. Similarly, in plasmalite, plasmalite is even more closer to your serum osmolarity of 290. Okay. So, and ringer lactate, ringer acetate, plasmolite, sterophondin are all balanced crystallites. This is your unbalanced crystallites. So, when you see this, you know that this RL or plasmolite is more physiological compared to your NS, right? Next is your dextrose containing fluids. They differ only in the dextrose content, like how much dextrose is present in 100 ml. For 5% dextrose, it is 5 gram, 10% is 10 gram, like that. And half NS is just half the content of your normal saline. Okay. So what are you going to give, electrolytes or colloids? See, earlier colloids was used because they thought that they have a very good volume expansion, three times the volume expansion. It's only theoretical. In clinical studies, they have showed only 1.3 to 1.4 times the volume expansion compared to crystalloids. So there are two trials, success and just trial. They compared starch to the crystallite solutions. They have totally proved that usage of colloids, starch-based colloids, causes increased mortality and increased incidence of AKI. One study was the crystal study. They showed some benefit with colloid compared to crystallites, but there are certain limitations in the study. In the colloid group, they used mixture of colloids. They used gelatin, they used aluminum, they used hetastarch. So it's not homogeneous. Another problem is their primary endpoint was 28-day mortality. But what they said was there's no difference in 28-day mortality between crystalloids and colloids, but 90-day mortality was better in colloid. When they further retrospectively inspected the study, they found out that some patients in the colloid group, they continued to receive colloid even after 28 days. They received some patients received colloids up to 90 days. So probably late when you give colloids very late, not in resuscitation phase, maybe it would have been helpful. So in generally, colloids are outdated now, except for aluminum. Okay, only crystallites are safe. Okay. And there are two trials comparing crystalloids and albumin. Okay, one is safe study. It compared normal saline with colloid, 4% albumin. 4% albumin because of hypooncotic nature. In traumatic brain injury, there's blood-brain barrier is disrupted. Albumin crosses the blood-brain barrier, behaves a hypooncotic, loss more fluid, increases cerebral edema. So avoid in traumatic brain injury. Next is albio study. Compared albumin to crystalloids. Okay, this concluded colloids, that is albumin alone, can be used in septic shock after large volume of crystalloid resuscitation. If patient is having persisting septic shock, colloid can be used if patient is needing large volumes of crystalloid. This is what they concluded in the surviving sepsis guidelines as well. So there are specific indications for albumin, and hypoalbuminemia is definitely not one of them. So indications include when a patient with CLE is undergoing a large volume paracentesis of more than 5 liter, hepatorenal syndrome, spontaneous bacterial peritonitis, or in a later stage of refractory shock when large volume electrolytes are required. This is recommended by the latest surveying sepsis guidelines in 2026. And patients with burns usually when more than 20% when surface area of the burns, and as a part of plasma exchange. So 20% albumin is used in all these conditions. 4% or 5% are used as resuscitation, volume expansion. Okay. So this is about the crystallites better than colloids. So now, whether you can use NS, we saw that RL is more physiological than NS. Plasmolite is more physiological than RL than NS. So what is the problem with using NS? NS, high chloride load, hyperchloremic metabolic acidosis, cause renal vasoconstriction and AKI. So up to 1 to 1.5 liter of NS you can use in a day for shock resuscitation. Okay. So the ESICM guidelines, they recommend that you use balanced electrolytes compared to NS in most patients, except with traumatic brain injury and coexisting hyponatremia. Because of isotonic nature of crystalloids, probably they increase the mortality. That is what they found. Only in select cases of traumatic brain injury and coexisting hyponatremia, they have told NS is better. All other cases, balanced crystalloids are better than NS. And they suggest against using 3% saline as a volume expander. Earlier I told you, because of hyperoncotic nature, it pulls the fluid into intravascular space and expands volume. But they suggest against using this for resuscitation. Okay. But there are various trials of them. Split, salted, smart. Then you have the upmast, basics, best, fluids, and plus trial. So they all compare crystalloids versus NS. I mean, balanced crystalloids versus NS. So split, salt, TD, smart. Okay, so we'll see what was the outcome. So there was no reduction in mortality between the balanced crystalloids and NS in all these three studies. But in salt TD trial, and in SMART trial, there was a reduced incidence of MIG-30 when patient received balanced electrolytes. MIG-30 means major adverse kidney events on day 30. So less incidence of AK and RRT when you're using a balanced electrolytes. No difference in mortality. Similar finding was found in fluid trial in 2023, basics trial in 2022, and plus trial in 2022. So one thing you have to remember, in all this study, there was small risk reduction in fluid mortality rate, but it was not statistically significant. That is why still they are not telling to ditch normal saline totally. Small absolute risk reduction in mortality in patients who received balanced electrolytes than NS. Okay. So next, there are some myths, and I want to clarify this myth with some facts. You may think that patient is having increased lactate in ABG, so I don't want to give RL. Is it true? No. Lactate present in RL is like a buffer, sodium lactate, not as lactic acid. This sodium lactate is almost always metabolized by liver and kidney to bicarb, and this bicarb in fact improves your acidosis and helps in bringing down the lactates. So unless patient is having a decompensated chronic liver disease (DCLD), there is no contraindication for using lactate RL in patient with lactic acidosis due to hyperperfusion and shock. Next is RL is having potassium, patient is having hyperkalemia, so I'm using NS. So remember again, one thing by getting metabolized in the liver, the lactate is converting to bicarbonate. This improves acidosis. Because of this correction of acidosis, potassium moves back into the cell, thereby reducing the serum potassium levels. And because of high incidence of AK with use of NS, this AK further exacerbates the hyperkalemia. Still, RL is better than hyperkalemia as well. Okay, next in Hartmann solution and Ringer acetate, they use acetate as a buffer instead of Ringer lactate. So you can safely use in DCLD patients having elevated lactates. This is a theoretical advantage, but again, there is no significant data on it. And one more thing, you would have seen plasma rate is better than RL in terms of osmolality and more physiological to the body's content. But we might say that it might have lesser metabolic complications, but there is no data or evidence to support its mortality reduction. Another thing to be considered is availability and cost of plasma rate over RL. Okay. So the next question here is when to give. So basically three indications where we give fluids. One is hypovolemia, next is maintenance, third is a vehicle for drug delivery. Okay. So hypovolemia is present in all types of shock. Even in cardiogenic shock, there is some amount of hypovolemia. So we need to address this hypovolemia, increase the preload, and increase the stroke volume so that the cardiogenic shock will improve. Okay. Then there is something called absolute and relative hypovolemia. So in septic shock, there is both absolute and relative hypovolemia. Relative hypovolemia because of the vasodilated state, and absolute hypovolemia because in sepsis there is endothelial glycocalyx disruption causing a leaky capillary. So this interstitial fluid leak will be there. So volume will be reduced. So that is both absolute and relative hypovolemia. Okay. So when you see a patient with hypovolemia, so when you see a patient with hypovolemia, you're going to give two types of fluid. One is a fluid bolus, next is a fluid challenge. Both of them are different. Fluid bolus is a therapeutic manual where you give large volume of fluid in short time without monitoring for the responsiveness. Whereas fluid challenge is a comparatively lesser volume in a shorter time, only to 200 ml and over 25, 10 to 15 minutes. And assess for fluid responsiveness. There are two different concepts, entirely different: fluid responsiveness and fluid tolerance. Fluid responsiveness is the ability of the heart rate to increase cardiac output when you give a fluid challenge. Okay, you give a fluid, cardiac output increases by 10 to 15%. This means the patient is fluid responsive. Patient is on the ascending limb of Frank-Starling curve. We already saw what Frank-Starling curve is in my previous video on heart-lung interactions. Please go and see it if you don't know about it. So here, patient is fluid responsive. You can give additional fluid. But fluid tolerance is the ability of the patient to accommodate this additional fluid without showing any symptoms of volume overload or fluid congestion, venous congestion. Okay. So a patient might increase his cardiac output once you give a fluid challenge, or sometimes this fluid may cause venous congestion. So patient may be fluid responsive, but fluid intolerant. He may go for congestion. Okay. So we need to assess both. So based on this, they have divided the hemodynamic profile into four types. Type A, B, C, D. A is when patient is both fluid responsive and he is tolerating the fluid. You can give more fluids for this kind of patient. A B profile, where the patient is not responding to fluid, but he is tolerating fluid, means he is not increasing his cardiac output or BP. Same time, he's not showing any signs of fluid overload or congestion. In such cases, you don't have to keep giving boluses because he's not responding. You can give a conservative fluid approach for this patient. Next is type C profile. The patient is neither fluid responsive nor he's tolerating the fluid. Not tolerating means he's going for congestion. In such case, you have to deresuscitate the patient and use some diuretics along with vasopressors. Means patient is fluid responsive, D profile. Patient is responding to fluid, but he's not able to accommodate the additional fluid and is going for venous congestion, fluid intolerant. In such case, go for vasopressis rather than pushing more fluids inside. So how you assess this fluid responsiveness and fluid tolerance? Fluid responsiveness is by hemodynamic indices, static and dynamic. We'll be seeing all that in the subsequent videos, in next video. And fluid tolerance, there is something to assess the right side and left sided circulation. For left side circulation, pulmonary artery occlusion pressure, E by E prime, E by A, lung USG, extravascular lung water, and pulmonary vascular permeability index. Right side circulation by trends of CVP, VEXAS, and IVC. We'll see this all in the hemodynamic class. Okay. My next question is how we are going to give. Antibiotic stewardship. Remember, fluid is also a drug. Okay, so remember like the same concept of antibiotic stewardship here, fluid stewardship. There are 4 Ds and 4 Rs in fluid administration: drug, dose, duration, and de-escalation. Drug here is the fluid. What fluid you're going to give? Choose the right fluid and right dose, and for the right duration and de-escalation. 4 Ds and 4 Rs. There are various phases of fluid resuscitation. Most popular one is the ROSE concept: resuscitation, optimization, stabilization, and evacuation. Here, instead of evacuation, they have termed it de-escalation. Here, instead of resuscitation, they have termed it salvage. Essentially, all are same only. So, resuscitation phase. Our target here is to resuscitate and save or rescue the patient. Early adequate fluid you're going to give. Our aim is to restore the intravascular volume rapidly, mainly in patients with absolute hypovolemia. And by maintaining the intravascular volume and rescuing the patient, we are trying to maintain a tissue perfusion that is just enough for the survival for organs. Okay. So here there are some targets of resuscitation. You have to maintain a bare minimal map of 60 to 65, monitor the capillary refill time, lactates, urine output, and the GCS. That is the 4 typical windows of perfusion you have to monitor. These are going to be targets of resuscitation. So how much you're going to give as a resuscitation fluid? There are two different recommendations. One is the latest surviving sepsis guidelines, 2026 guidelines, which was my previous video. They say that at least 30 ml kg in 3 hours, whereas ESICM says up to 30 ml, at least 30 ml or up to 30 ml. So final decision is it should be based on the context of the patient, individualized based on the patient. One size does not fit all. Okay, there is a small flow chart which I like to share. This is not a strict dictum you have to follow. Just for example, suppose patient is coming and you're giving a fluid challenge at the rate of 10 ml per kg in the first 30 to 60 minutes. If suppose patient is having signs of hypoperfusion, like increased lactate, increased capillary refill time, or ongoing loss, you can increase this rate of 10 ml per kg to maybe 30 ml per kg. Whereas when you're giving this 10 ml per kg itself, if patient is going for volume overload features like tachypnea or desaturation, then you reduce the rate. Start with 10 ml, patient is improving or patient is still having signs of shock, increase the rate. And if once you increase the rate, you assess for, before increasing the rate, you assess for the fluid responsiveness. Like this hemodynamic indices. If patient is not responding for fluids, go for vasopressis. If patient is responding for fluid, you see whether patient is having ARDS or not ARDS. Whether patient is having ARDS or he is at risk of developing ARDS. Because in ARDS, we generally try to target a little bit negative of fluid. You don't want to congest the lungs. So that is you can assess by some parameters like ultrasound, lung ultrasound, VEXAS score, extravascular lung volume, pulmonary vascular permeability index, and all those things. If there is a high risk for developing ARDS or he is associated with ARDS, then you go for vasopressors. If there is no ARDS risk and he is responding to preload, you further increase the fluid bolus. Okay, you can increase the fluid. It's just an example for understanding. So once after you give the initial bolus, further fluid to be given depending upon fluid responsiveness, dynamic indices preferred over static indices. Next is the optimization phase. So optimization phase, your main target is to you rescue the patient in resuscitation phase. And we are trying to rescue the organ by maintaining the organ perfusion and improving oxygen availability at cellular level. So organ rescue and maintenance of organ perfusion. Same time, we don't want to give cause organ congestion. So you try to avoid the fluid overload and fluid creep. Maintenance fluid is needed only if needed. So this time in this phase, you're going to give fluid based on the fluid responsiveness and tolerance. So whatever we give here in this phase, the fluid should stay in the intravascular space. You don't want it to go to the intracellular space and cause some fluid overload. So this is called conservative fluid management, early conservative fluid management, so that the fluid you give, if needed, it should be in the intravascular space and not go to the intercellular interstitial space. Next is the stabilization phase. You maintain the organ perfusion. Now you have to try to avoid this organ dysfunction, maintain organ homeostasis, and avoid organ congestion. Maintenance fluid only if needed. So this we try to target slightly negative or neutral balance, or you can go for a late conservative fluid management, which means 2 consecutive days of negative fluid management in the first week itself. Next is the evacuation or de-resuscitation, where you target a late goal-directed fluid removal, target negative balance. So this is typically the timeline. Resuscitation happens in minutes to hours, optimization in 6 to 24 hours, stabilization phase in the first 3 days, evacuation typically by third day onwards. And this is not always same for all patients. So resuscitation phase, it means patients coming in severe shock. It's an inflammatory insult. What you're going to do, you're going to try to save the life of the patient or salvage him and give a early goal-directed fluid, adequate fluid management And fluid boluses, you're going to give rapid boluses in the resuscitation phase. From this phase, patient may enter to a phase of severe shock to unstable shock, where there's a ischemia and reperfusion is the insult. Okay, in this, your target is to rescue the organ. In stabilization, patients start to recover from the shock. You're going to support the organ, rescue the patient, rescue the organ, and support the organ. And then later evacuation phase, you're going to recover the organ. So in towards the end of stabilization phase, what might happen? Patient might be in positive balance. If at all patient is having overload, we're trying to mobilize the accumulated fluid. That is what is going to happen, evacuation or resuscitation phase. Okay, fluid bolus in resuscitation, right by fluid responsiveness, maintenance fluid if needed in stabilization phase, and negative balance in the evacuation or resuscitation phase. Sometimes resuscitation may not work. So why is this? See, a mechanism of resuscitation, fluid resuscitation is when you give a fluid bolus, there is going to be increased venous return and increase in LV preload and increasing the cardiac output. Yeah. So they by increasing the preload, cardiac output improves and it increases the shift of unstressed to stressed volume and increase the mean systemic filling pressure. By this, the cardiac output increases and blood pressure improves. We have covered already what stressed volume and MSFP is in our heart and lung interaction video. Okay. So this is the mechanism of fluid bolus in shock. But when it might not respond, why patient might not improve BP? This is because patient might be on the flat part of the flank Starling curve. Only if patient is the steep part, is fluid responsive. If patient is on the flat part, it means patient is already in the fluid overload state. Giving more fluid in this patient, it causes only congestion. Okay. So remember, patient might be having shock, septic shock. Already he might have endothelial injury and glycocalyx, and he might be in the flat part of the Frank Starling curve. You're giving more fluids to them, the extra fluid is going to exacerbate this injury, and it might only worsen the perfusion, and it continues like a vicious cycle. This is one reason why patient might not respond to the resuscitative fluid. Next reason is shock might not always be due to tissue hyperperfusion. Sometimes it happens at a cellular or tissue level. Okay, because of this, patient may not respond. And fluid responsiveness in shock usually decreases with time, and these hemodynamic changes are usually short-lived because of the fluid. Other reason, yeah. So what we try to do, they have in surviving sepsis guidelines, they have asked to initiate vasopressors early along with fluid resuscitation, especially when patient is having wide pulse pressure, a shock index of more than 2.3, or already if more than 1 to 2 liters of fluid is given. So keep assessing for fluid responsiveness and tolerance, and only if patient is not having any existing renal and cardiac dysfunction, you're going to give resuscitation fluids. Only in such cases it might work. In other cases, you initiate early vasopressors. It is shown to improve the outcome. When you're going to stop the resuscitation phase and go to move on to next phase, if there is positive signs such as there is a targets of resuscitation is achieved, such as MAP, lactate, capillary refill time. If patient is improved, you can stop the resuscitation. Or negative signs such as fluid intolerance or unresponsiveness, or there is a hemodynamic incoherence. Hemodynamic incoherence means there is an improvement in macro hemodynamic parameters. Cardiac output or MAP is increasing, but the microcirculation in terms of lactate, capillary refill time is not improving, which means there's a loss of coherence between the macro hemodynamic parameters and microcirculation. In such cases, also, you have to stop the resuscitation fluids and go for vasopressors. And next, coming to maintenance fluid. So, in optimization stabilization phase, we go for maintenance or replacement fluid. This is only when patient is not able to take orally or if there is ongoing fluid or electrolyte loss. So, daily requirement, if you see, it is 1 ml per kg per hour for water, and 1 to 1.4 millimole per kg of sodium, and zero point 0.5 to 1 millimole per kg of potassium, and 1 to 1.5 gram of glucose every day. So this maintenance fluid should be restricted to 2.5 liters per day or 3 liters in some healthy individuals. And this is not same for all patients, especially in liver, cardiac, or renal failure. This is even much lesser. So we all know the Holiday Sager formula to calculate the maintenance fluid, right? 4 is to 2 is to 1. This we've been using since the time of OT days, right? So this rate of maintenance or replacement fluid should be based on windows of tissue perfusion such as urine output, mentation, BP, heart rate, ongoing fluid and electrolyte losses, ABG, and based on presence of other comorbidities. Another example, this is not a quick term again, just example for you to understand. If patient is euvolemic, stable hemodynamics, and urine output is good, go for a 60 to 120 ml. If patient is edematous and otherwise stable, you can slightly reduce for conservative fluid management 40 to 60 ml. If patient is oligo or anuric and edematous, you need to even still go down on the maintenance fluid. And if patient is having CNS pathology, it's better to give if patient is on CNS pathology and is already receiving hypertonic saline, remember hypertonic saline is hyperoncotic. It expands the intramuscular volume more. So patient, if he is on 3% saline, and you have to give along with this electrolytes, just reduce the rate or volume of the electrolytes. Okay. So in general, when do you want to give dextrose containing fluids? Patient with repeated episodes of hypoglycemia, or if patient is having hypernatremia, you're going to give dextrose containing fluid. Avoid in traumatic brain injury. They are hypooncotic. They drop more fluid into the blood-brain barrier and into the brain and cause cerebral edema. And two other things I want to say is in postoperative patients, they have increased ACTH, ADH, and cortisol. So they generally tend to retain water and sodium. In such cases, better to go for balanced electrolytes. And in critically ill patients, they generally have a altered arginine vasopressin system due to various reasons. Because of this, they generally tend to be towards hyponatremic. You can give NS, however, you can give RL also. No additional benefit of giving NS over RL. Next thing, what can happen during this optimization stabilization phase, which you want to avoid, is something called as fluid creep. Up to 30% of total intake which is going to a patient, it is because only as a vehicle of drug delivery or feed or when you're giving electrolytes or flushing of lines. Okay, this contributes to accumulative, slowly accumulates in your positive fluid balance, causes both water and sodium overload. This is usually unmeasured and unintentional. This is called fluid creep. Okay, there are some adverse effects. Previously, we used to say volume overload, fluid overload, hypervolemia, etc. Now they have become separate entities. Okay, so I'll try to simplify this. It might seem confusing. So what it is see, when you say hypervolemia, it means that extra volume is there in the intravascular space. Okay, not in the interstitial or intracellular space. So extra intravascular volume is hypervolemia. Extra total body water. Total body water is increased, which means both intravascular volume and intercellular volume is increased. That is, your total body water is increased. That is fluid overload. Here, both water and electrolytes are increased. But if the volume is only high in intravascular space, it is called hypervolemia. With this hypervolemia, fluid can get shifted from the intravascular to the interstitial later stage. So hypervolemia can later progress to the fluid overload state. Okay, this hypervolemia can be because of excess fluid given in these phases, or it can be secondary to the organ dysfunction. So this fluid overload is a older term. Now something a newer term called fluid accumulation is there. This fluid accumulation means patient might not show signs of clinical signs of edema like field edema, etc. might not be there, but patient is still in fluid overload. How do you find it? By cumulative balance. You check the cumulative balance over the past 2 or 3 days, and patient is in positive balance in the last 2 or 3 days. And when this fluid accumulation is more than 5 to 10% of the baseline body weight, we call it as fluid accumulation. Okay, so basically, fluid accumulation is nothing but fluid overload, but with the evidence of positive cumulative fluid balance. And one more thing, patient can have a fluid accumulation irrespective or regardless of his intravascular volume status, which means a patient might have cumulative positive balance, but still hypovolemia in terms of intravascular space, or normovolemia in intravascular space, or can be hypervolemic also in the intravascular space. So this is regardless of intravascular status, patient can still have fluid accumulation with positive cumulative fluid balance without signs of edema. This usually we determine it by see, for example, if patient is positive by 5 liters in the last 3 days, we divide 5 divided by patient's body weight into 100. That is the percentage of the fluid overload state. Okay. So something called fluid accumulation syndrome. So fluid accumulation with new onset organ dysfunction, not because of the primary illness. This new onset organ dysfunction is attributed to the excess accumulative fluids. Okay. And when the patient is in fluid accumulation syndrome with organ dysfunction, it need not be that patient is having more than 10% of baseline body weight. Even with 3 to 4% or even 5% of body weight, 5% of increase in baseline body weight with the new onset organ dysfunction, we call it as fluid accumulation syndrome. Okay. This is C. One more term called global increased permeability syndrome. This is same fluid overload plus new organ dysfunction. That is fluid accumulation syndrome with capillary leak, which we have determined by extravascular lung water index or PVPI or capillary leak index. So what happens? In capillary, the fluid gets filtered to the interstitial and venous compartment. 90% of the fluid that is getting filtered in the capillary goes to the venous, remaining 10% goes to the lymphatic system. Now, what happens when there is venous congestion? When there's venous congestion, the rate of capillary filtration increases. As more and more capillary filtration rate increases, more to some extent the lymphatic vessels can expand and accommodate the volume, but beyond the point they cannot. So when severe venous congestion, what happens? The pressure at the junction of SVC, IVC, and the lymphatic thoracic duct is increased. Because of this back pressure changes, because of venous congestion, impaired drainage of lymphatic system occurs. This impaired lymphatic drainage causes to progressive interstitial tissue edema and multi-organ dysfunction. Okay. To summarize this, yeah, before that, this GIPS global increased permeability syndrome is nothing but fluid accumulation syndrome with a capillary leak, which we have diagnosed by certain measures. This happens because the patient does not transition spontaneously from the flow phase to ebb phase in sepsis, and they remain in a state of continuous increased permeability. Okay. This is to summarize. So hypervolemia is when the intravascular volume is high. Fluid overload is when patient is having high intravascular or interstitial, both is increased. Patient can still have normal intravascular. So total body water is increased. That is fluid overload. So fluid overload is a older term for fluid accumulation. So fluid accumulation is you have determined by positive cumulative fluid balance. Evidence is there. Okay. So what is the pathophysiology behind this fluid accumulation syndrome or GIPS? So basically, it is a vicious cycle. Two cycles happen. So first, what happens? Sepsis or trauma causing inflammatory mediators. These injure the endothelial glycocalyx. Once this is injured, the capillary permeability is increased, causing a leaky capillaries. What is leaking? Protein-rich fluid is leaking from intravascular to the interstitial space. So because of this leak, there is reduced because of this leak of this protein-rich fluid, there is reduced oncotic pressure and tissue edema happens. This is one part. Sorry, leaky capillaries, protein-rich fluid is escaping into interstitial space. Because of this loss of fluid in intravascular space, preload is reduced, cardiac output is reduced. So we give more IV fluids. What happens when you give more IV fluid? The endothelial degradation or injury is again uh, exacerbated. Giving more IV fluid in already leaky capillaries, it only exacerbates the endothelial damage. Other problem when giving more IV fluids is it causes the increased intra-abdominal pressure, thereby reducing renal and hepatic perfusion, and they tend to cause intercompartmental deterioration. Certain new terms are there: cardio-abdominal renal syndrome, hepato-abdominal pulmonary syndrome, or hepato-abdominal renal syndrome. Okay, this is one kind of vicious cycle. Okay, another vicious cycle is, so you see this protein-rich fluid is going from where to where? From intravascular space, there's loss of intravascular space, capillary leak. It goes to the interstitial phase, interstitial space. Excess interstitial fluid, what happens? It reduces the oxygen and micronutrient diffusion. And because of this, again, there is disruption of endothelial glycocalyx, again causing reduced capillary blood flow and lymphatic drainage, causing tissue hypoxia and leading to MARDS. Once patient enters the state of MARDS, these affected organs are less tolerant to even little excess of fluid. Then what they do? They again cause compartment syndrome and MARDS worsen. Basically, inflammatory mediators, glycocalyc degradation, leaky capillaries, loss of fluid from the intravascular to the interstitial space. This causes a vicious cycle. Okay. Another vicious cycle is because of the loss of fluid, we give more fluids. More IV fluid is we again indirectly causes endothelial lipid degradation. So this cycle keeps continuing again and again. What are the triggers? Sepsis, burns, trauma, severe pancreatitis, post-cardiac surgery. Okay. And it's very difficult to diagnose fluid accumulation syndrome. There's no single test. We need a high index of suspicion and generalized non-specific signs like field edema, peripheral edema, anasarca, respiratory distress, Krebs. All these are non-specific. We have certain specific signs. So what happens in the AS system if patient is going for a fluid accumulation syndrome or a CHIPS? So we'll go from head to toe. So what happens in the brain? Because of capillary leak and impaired autoregulation, there is raised ICP, cerebral edema, which may cause cognitive dysfunction. Next is your lung. So there is increased extravascular lung water, which impacts the gas exchange, like hypoxia and hypercarbia, causes ARDS, pulmonary edema, increased work of breathing, accumulation of fluid, pleural effusion. Because of this, difficult weaning happens. Next, at the cardiac level, there is the ventricular dysfunction, myocardial injury. Okay, because of all this, there's myocardial edema, impaired contractility, renal venous congestion, and causing arrhythmias and pericardial effusion, and it increases the pericardial pressures and filling pressures. Next, tissue level, what happens? It causes tissue edema. And why is this? See, impaired oxygenation and nutrient deficient. This causes tissue edema, impaired wound healing. Okay, impaired wound healing, and more chances of pressure ulcer and wound infection. Next is hematological. There is a hemodiluted state, anemia, coagulopathy. All these problems can occur. Next, renal. There is increased, because of venous congestion, increased venous pressure. When the venous pressure is elevated, there is reduced renal blood flow. Where here, renal blood flow and reduced GFR because of the renal venous condition, causing compartment syndrome, altered renin angiotensin aldosterone axis, causing water and salt retention. Ultimately, AK is progressing. What happens to the bowel? Mechanism is edematous bowel wall, causes the dysfunction of the barrier. So there is bowel dysfunction, bowel wall edema, reduces the bowel motility, motility translocation can happen, splanchnic ischemia, accumulation of fluid causing ascites, intolerance to fluids. Intolerance to enteral feeds. Same thing for hepatic, increased hepatic venous stasis, hepatic congestion, cholestasis, and acute liver injury can happen. Okay. And again, delayed wound healing, tissue hypoxia, all this contribute to the pathology of increased fluids. So how can we diagnose this? Some tests are there, like capillary leak index, albumin leak index, lactates, ABG, even electrolytes. What you see is FINA here, and you see capillary leak index is nothing but CRP divided by albumin. Okay, and certain crude tests like in chest X-ray, you see features of pulmonary edema, pleural effusion. Okay, and the means of global end diastolic volume index, global ejection fraction, central venous pressure elevation, pulmonary artery occlusion pressure is elevated, end expiratory occlusion test, and all these are signs of fluid accumulation. And ultrasound, you're going to see E by E prime is reduced, and reduced BTI variations, IVC diameter, Vexus score, lung ultrasound, and in invasive monitoring, you can see extravascular lung volume index is elevated, pulmonary vascular pressure index is elevated, your shunt fraction is elevated. and all this, and bioelectrical impedance analysis, total body water index. All these are some of the measures. We'll see all about all this in your thermodynamic videos. Nothing to worry. Okay. So other tests like yeah, this is the same what we discussed. Daily cumulative body weight, daily cumulative fluid balance, ultrasound, echocardiography, invasive monitoring, and non-invasive is a bioelectrical impedance. This bioelectrical impedance analysis is excellent non-invasive tool. Okay, it measures total body water, extracellular, intracellular water, and all these things. It measures the very high accuracy. Okay, and if you have invasive, you can measure the extracellular lung volume index. Okay, lung water. Ah. So now next question is how we are going to prevent the fluid overload. This is mainly prevention is easy. You follow the fluid stewardship during resuscitation, individualize the fluid based on fluid responsiveness and tolerance in optimization and stabilization phase. Go for a conservative fluid strategy in selective patients. Studies have shown there's no mortality benefit, but there's no harm also. So in selective patient groups, you can go for conservative fluid management, early initiation of vasopressors, and always remember fluid creep. Okay. So how we are going to manage? Coming to the deresuscitation or evacuation, last phase of the ROSE concept. So this is when you're going to start. When organ dysfunction persists despite the resolution of primary insult, and this is attributed to the fluid overload. Okay. So this sometimes we ideally say the E phase or D phase starts in days 2 weeks. That's third day. Sometimes this can happen early depending on the clinical scenario. So it's a subjective and physiological concept. So you're going to see the vasopressors are reducing in time, lactates improving, and there is sign of fluid intolerance in either in the ABG or in ultrasound and other assessment. So if the above features are present, we have to start targeting neutral to negative fluid balance, late conservative fluid management. Okay. There's something called capillary leak index. This is elevated in capillary leak index is associated with persistent capillary leak, and these patients are more prone for global increased permeability syndrome. Capillary leak index is CRP divided by the serum albumin. Okay. This is just a confidence trial which is going. It's ongoing trial. You'll have to wait for the results. So what are the challenges during the resuscitation phase? See, there's something called transcapillary refill rate. This is the rate of fluid shift from the interstitium to the intravascular space. This mainly depends on the integrity of the glycocalyx. So when deresuscitation happens, we're trying to remove the extra intravascular volume. When this extra intravascular volume is removed, the fluid is being shifted from the interstitial to the intravascular compartment. This again depends on the transcapillary refill rate. Any failure of this shift of the fluid from the interstitial to the intravascular space causes compromise and causes tissue hypoperfusion and hemodynamic instability. This might not get shifted. Intravascular volume still remains empty after the deresuscitation. This causes worsening of the sharp tissue hypoperfusion, hemodynamic instability. Vasopressors and diuretics may aid in this shift. Diuretics reduce the intravascular volume and facilitate the shift once the transcapillary rate is more than the removal rate. So do not assist excessively aggressive diuretics. Okay. And vasopressors during this phase may help prevent the hemodynamic instability. And if there's any hemodynamic instability during the resuscitation, then we have to slow down the process of deresuscitation. So next we'll see how we are going to do this deresuscitation. Before that, certain points to remember: conservative fluid management versus active deresuscitation. There's no difference in mortality. So avoid aggressive fluid removal in certain patients, such as MI patients, cardiomyopathy, stress-induced cardiomyopathy, etc. Okay, because this aggressive fluid removal causes more myocardial injury. So how you know the diuresis or deresuscitation is adequate? Try to target urine output for 3 to 4 ml per kg. Do not try to target more excessive diuresis. Okay, when the urine output is 3 to 4 ml per kg, it means it's a good marker of adequate intravascular volume is there. It's not causing too much of intravascular volume depletion. When you start this deresuscitation phase, chances of dysarthritemia or AKI and coagulation abnormality occurrences there. So you need to monitor all these apart from your regular monitoring of lactate and capillary refill time. So there are some methods of resuscitation. Physical methods include usage of venous compression stockings. Basically, the basis is that they increase interstitial pressure, reduce the capillary leak, and promote lymphatic drainage. Pharmacological, obviously diuretics. Loop diuretics is preferred. Next, you add a second line of diuretics if the furosemide requirement is excess, okay, or if patient is having hypernatremia. Usual choice is thiazide or thiazide-like diuretics, including metolazone. Okay. Before initiating this, we have something called as furosemide stress or furosemide challenge test. In a patient who's never been exposed to furosemide, you give a bolus of 1 milligram per kg. Or a patient who's been exposed to diuretics before, use a dose of 1.5 milligram per kg. After taking the challenge of Lasix, the urine output is more than 200 in the next 2 hours. It means patient is ready for the deresuscitation phase. If tested negative, patient is not yet produced more than 200 ml of urine. High chances that patient is can go for a stage 3 of AKI and may end up in dialysis, and don't give more boluses of Lasix. Do not continue with the deresuscitation by means of diuretics. And whether you have to give bolus doses of Lasix or infusion, bolus versus infusion, there's no difference. However, greater negative balance have been achieved with infusions. Next is something called as PAL treatment. Deep albumin and Lasix. Albumin with Lasix happens only when when patient is having hypoalbuminemia, he may benefit by adding Lasix to the albumin. Okay. So PAL treatment is nothing but adjusting the PEEP to counteract elevated intra-abdominal pressure, usage of 20% albumin and Lasix. When the PEEP is equal to or more than intra-abdominal pressure, the effect of the increased pressure on diaphragm is reduced, and by facilitating the lymphatic drainage and more alveolar recruitment. In this Lasix 60 milligram stat followed by infusion rate, which varies for the first 4 hours between 5 to 40 milligram. Then after the 4 hours, you go for a slightly lower dose, 5 to 10 milligram per hour. Okay, this PAL treatment is found to cause better negative balances, reduces the extravascular lung water, and reduces the intra-abdominal pressure. It should be done with extremely high caution in patients who are hemodynamically unstable. Okay. The downside is that we may raise the CVP and impair lymphatic drainage, thereby causing fluid accumulation. So don't go very high on the P. Next is non-pharmacological, like renal replacement therapy. Again, choice of dialysis should be decided based on individual patient. Targeting of 2 ml per kg per hour of alcohol filtration seems to be irrespective, whether it is SLEC or CRRT, and they try to reduce the extravascular lung volume without reducing the cardiac output or preload. And hypertension is not a cardiac contraindication for diuretics or RRT if we see the patient is in fluid accumulation syndrome. So when do you want to stop the phase of deresuscitation? One, you have done the deresuscitation and the patient is improved in terms of oxygenation or organ perfusion. You stop with the deresuscitation. Or if patient is worsening after deresuscitation, which means he is not tolerating the excess fluid removal, such as by signs of increasing lactate or signs of reduced cardiac output. There is no universally accepted gold standard test to either start or end this test. So in case you begin the deresuscitation and patient is showing worsening symptoms, you have to re-resuscitate the patient with the help of albumin or vasopressors preferred. Okay, again, there is no mortality benefit by meta-analysis, but some smaller studies, individual studies, have showed some improvement in terms of AK and length of stay, especially in patients who are mechanically ventilated and ARTS. So this is summarizing the 4 phases of fluid resuscitation. See, initially patient is having inefficient microcirculation, hypoperfusion, and disorders in oxygen delivery. The patient is having uncontrolled capillary leak and dehydrated cells. You go for resuscitation phase. Once you start this, what happens is this uncontrolled capillary leak becomes partially controlled capillary leak, and this patient might have corrected oxygen delivery. And because of the resuscitation phase, there is initially uh, this intravascular fluid which you're given might not tend to stay in the intravascular compartment. They may go to the cellular compartment, and this is uncontrolled process, causing extravascular fluid shift. Means the fluid is getting shifted from the intravascular to the interstitial or intracellular space. So the cells are starting to swell. This happens in the optimization phase. Next, what happens? You have corrected the hyperperfusion, and microcirculatory perfusions also become adequate. Oxygen deliveries also become adequate. Now what happened? The capillary leak is slowly starting to get controlled. Now what happened? The excess fluid which are given in these 2 phases is starting to accumulate in the intracellular space and causing cellular and tissue edema. Okay. So now what you're going to do? You're going to enter the phase of evacuation, deresuscitation. Okay. So here microcirculatory perfusion is adequate, oxygen delivery is adequate, and you have to start reducing the tissue and cellular edema. That is, these are the triggers when you want to start the evacuation. This is evacuation is done by diuresis or RRT, target negative balance, deresuscitation phase. Some triggers are these measures, invasive hemodynamic monitoring. And once you start the deresuscitation phase, when you are going to stop, patient is worsening, lactate is increasing, or there is no improvement in cardiac output with respect to fluid. Okay. Or mixed venous oxygen tension is reducing. In such cases, you want to stop the deresuscitation phase. Okay. So to summarize, I want you to remember this take home messages. Fluid stewardship, just like antimicrobial stewardship, remember the 4D and 4R: right patient, right indication, right drug, right duration, and 4Ds. Okay. Drug, dosing, duration, and de-escalation. Those concept. Always check for fluid responsiveness and tolerance every day. Make it a practice. And prefer dynamic indices more than static indices. Balanced electrolytes have some advantage over NS. However, NS is not totally dished. Remember about fluid creep. Take into account all the intake sources like feeds, antibiotics, electrolyte infusions, and other things. Okay. And for deresuscitation, you need to have a high index of suspicion for fluid accumulation syndrome. Sometimes you need not wait till the third day. You might have to start early. And so you're going to both monitor perfusion, hemodynamic monitoring for fluid responsiveness by perfusion, fluid tolerance by congestion. Both perfusion and congestion will be monitored. And it is a dynamic process. It might not be same for all patients. So that's it. If you have any comments, please let me know in the comment. Our next video will be on approach to shock and hemodynamic monitoring.